Today is the top collaborative webinar number 5. So the title of this one is Community Clozapine Titration Review of Treat, and this is going to be presented by Dr. Arumuham. Before we get into things, we'd like to do a land acknowledgement. We want to acknowledge that the land on which we gather is the traditional, ancestral, unceded, and occupied homelands of the Coast Salish peoples. We also want to acknowledge that others may be joining from different traditional homelands today. This acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous peoples in our healthcare system. We also want to acknowledge the organizations that have been supporting this series of learning for us with the top collaborative. The BC CFE, Vancouver Coastal Health, the VGH UBC Hospital Foundation, and the British Columbia Schizophrenia Society have all been integral in funding and supporting the work we've been doing here. We want to give a special acknowledgement to the team within the teams within the team, within the BC CFE, the IT, the comms team, and the education teams have also been integral in rolling out many of the education sessions we've been able to attend. I'm going to pass it off to Randall to introduce our speaker for today. Randall.
Thanks, Philip. So welcome, everyone. And it's my pleasure to introduce our speaker today, Dr. Arumuham, who goes by Ati. He's a specialist in psychiatry, and he's a PhD student. Completed his medical degree at the University of Birmingham in the UK, and also has an MSc in medical leadership from Lancaster University. He joined Professor Oliver Howe's neuroimaging group in 2018 in the Medical Research Council London Institute of Medical Sciences as a clinical research fellow, and subsequently joined the Department of Psychosis Studies at the Institute of Psychiatry, Psychology and Neuroscience, King's College London as a clinical research associate. Continuing his work with Dr. Howe's. And he, in terms of clinical practice, joined the Treatment Review and Assistance Team, or so-called TREAT team, South London and Maudsley NHS Foundation Trust, as a psychiatrist. His current research for his PhD began in 2019 and explores the neurobiology of cognitive function and psychosis. And he uses imaging technologies such as PET and fMRI. Today, though, he's going to talk about the study that was recently published in the British Medical Journal about community-based clozapine initiation. And of course, this caught our eye because that's exactly what we're working on. And so we have this exciting opportunity to have a dialogue with the team in London. So I will turn it over to Dr. Arumuham.
Thank you very much, Randall. And just give me a moment. I'll switch over to my slides. Brilliant. Can you all see that? Fantastic. Okay, so thank you for having me here to present our findings to you this morning. As Randall mentioned, my name is Ati, and I'm a clinical academic based at King's College London and South London and Maudsley NHS Foundation Trust, also known as SLAM. So you'll see that little acronym quite a few times during the talk as well. Clinically, my role centers around treatment-resistant schizophrenia, in managing complex mental and physical health symptoms, adverse effect management, and community clozapine titration. And today I'll be talking primarily around community clozapine titration through our specialized clinical service TREAT and evaluating its progress so far. So first of all, let's go through some learning objectives. So we're starting with learning about the TREAT model of community titration and how this could potentially be applied to your practice. We'll then go over the method behind evaluating the service, the so-called mirror study that has recently been published. And finally, we'll discuss findings from the study and the clinical and financial implications of those findings as well. So some background on treatment-resistant schizophrenia. Compared to patients who show an adequate response to treatment, patients with treatment refractory illnesses have been consistently found to have a reduced quality of life, increased care costs, and increased rates of serious comorbidities, with cardiometabolic conditions in particular developed through lifestyle habits, medication, and disease progression itself having been found to be the most significant cause of reduction in life expectancy. Now, interestingly, the quality of life of patients in this cohort have been found to be patients similar to patients receiving maintenance dialysis in end-stage renal disease as well, so showing a really impaired quality of life in this group. The medical costs of treatment-resistant schizophrenia is thought to be 3 to 11 times higher than schizophrenia, which is response to treatment, with a large range due to projection of the loss of earnings and social care needs as well. The prevalence of schizophrenia is thought to be around 0.3 to 0.6% of the population as a whole, with variations according to location, such as high prevalence in urbanized cities. And within this population, it's estimated that approximately a third are treatment resistant. And amongst patients with treatment-resistant schizophrenia, there is another subset of a third, which is known to perhaps not respond to clozapine either, and that condition is known as ultra-treatment resistance, but we won't venture too much into that later unless you're interested in the questions later. Patients with treatment-resistant schizophrenia have twice the rates of hospitalization as non-treatment resistant, along with relapses and severity of illness. This is also as a result of some patients requiring admission for the initiation or retitration of clozapine as well. So with the significant impact on the lives of patients and the healthcare system as a whole, it's important to consider how to optimize care of patients with refractory illnesses to improve both their prognosis and the cost implications on healthcare. So I'm sure you know what treatment-resistant schizophrenia is, and there's been many definitions, including persistence of symptoms despite more than 2 adequate trials of antipsychotics for appropriate duration and with documented adherence. But there have been many kind of expert opinions and criteria that have come out since, including the TRIP criteria, which is aimed to refine publications of research to give a more standardized definition. But the reason why I put this Venn diagram up here is that, besides all the important research and jargon that perhaps comes along with it, I think it identifies that the way to properly identify treatment resistance is through a comprehensive initial assessment to identify early the onset of illnesses, especially if we've seen the consequences that we've discussed earlier in the backgrounds as well. As I mentioned slightly earlier, clozapine is obviously the drug of choice for treatment-resistant schizophrenia. It's the only licensed medication to manage symptoms of treatment resistance as well. Multiple studies have shown its efficacy over other standard antipsychotics. And this more recent meta-analysis published by Dr. Yuya Mizuno, who's a colleague of ours over at King's and SLAM as well, found that clozapine was superior in managing symptoms of treatment resistance with a moderate effect size of about 0.4. So given its superior efficacy, clozapine should be used as indicated to reduce duration of untreated illness, which evidence has shown to worsen the prognosis of these patients. And there's a good meta-analysis by Dr. Martin Asugo, who I think was published last year, which did an umbrella meta-analysis on duration of untreated psychosis and outcome factors, including PANSS as well. However, studies have found delays to initiation of clozapine, as I'm sure you're aware as well. Oliver House's paper found a mean delay of over 4 years to initiation, with quite a broad range after identifying treatment-resistant schizophrenia. And there are several interesting features identified in patients where clozapine was delayed. First of all, multiple treatment options were trialed before initiation of clozapine, with an average of 6 different treatment episodes on 4 different antipsychotics. A third of these patients were treated with polypharmacy, while another third were treated with unlicensed high doses of antipsychotics as well. So this paper and others have found several barriers to initiation of clozapine that can be categorized broadly into these factors, so health service factors and patient factors. And under health service factors, we can see here that from Oliver's paper, 2/3 of psychiatrists in the UK reported not having recent experience of titrating clozapine, while another third stated they did not know it could be titrated safely in the community without the help of a home treatment team. I'm not sure if, I'm sure you guys have some equivalent of home treatment team, but I'll give a brief summary of what they do. They're almost like an intermediary between community care and inpatient care. Where they aim to address patients at high risk of requiring hospitalization. So whether it's for relapse of symptoms or non-adherence with medication, they need support to prevent a subsequent admission. They also have some availability to facilitate a community titration, but their resources are limited because it requires them doing multiple home visits throughout the day. So I think their current protocol is 4 visits during the day during the titration phase, and they have to stay for a few hours each time for monitoring of physical health symptoms, of blood pressure and things like that. So they only have limited spaces, which goes quite nicely to the last bullet point as well, with which is that clinicians mentioned there was a lack of resources as a whole. So whether it's inpatient beds that are limited, and because HTT can only handle a handful of patients due to demand on staff for regular monitoring. In patient factors, we have the common ones, which are dislike of monitoring requirements, which varies from refusal to go in for hospital admission despite them feeling well otherwise, for initiation of clozapine, and also the regular blood tests required as well. And there's also considerable concern around the adverse effects. But focusing on healthcare-related barriers specifically, and particularly use of multiple other antipsychotics and polypharmacy, despite an established diagnosis of treatment-resistant schizophrenia, there's often a sense that clozapine initiation is a specialized process and not for the community teams to initiate. So the question arises, what happens should clozapine initiation be delayed? Now, one study addressed this by performing a retrospective chart review of about 90 patients with treatment-resistant schizophrenia who had been established on clozapine for at least 3 months, and determined whether there was a relationship between a delay in clozapine initiation and response. They defined response as a 40% improvement in the BPRS score. And after performing a receiver operating characteristics curve analysis, the group found a threshold of treatment delay of 2.8 years, which you can see on the graph. And those who were treated within that time had a 82% response rate, while those with longer delays, they found to have a 31% response rate. So all of these findings in culmination kind of indicates the importance of, firstly, a prompt diagnosis, followed by a prompt management of patients with treatment refractory illnesses to provide them with the best clinical outcomes and quality of life. Now, to address this, the TREAT service was developed over 10 years ago. So the TREAT service, also known as the Treatment Review and Assistance Team, is a specialised service in South London and Maudsley NHS Foundation Trust, also known as SLAM, and was established as a service model to provide expertise and additional clinical resources to assess and treat patients with treatment-resistant schizophrenia. And having been set up around 10 years ago, its primary aim was to address clozapine treatment hesitancy and facilitate community titration, thereby relieving the burden from inpatient and home treatment team services. Following our own kind of QI processes and improving our service as a whole, we also noticed other niche areas of care that we thought were perhaps under-addressed in typical mental health care reviews. So we've developed separate services within TREAT as well to look at these kind of niche symptoms. So they include a negative symptom service. So this specializes in reviewing and managing patients who have prominent negative symptoms as part of their illness, and also a movement disorder clinic, which collaborates with neurologists for the treatment of tardive dyskinesia in particular. The picture here includes all the current cohorts of the treat clinicians, primarily made up of doctors with a clinical nurse specialist and our administrator, Emma, who you can see on the far right, Emma Butler, who was a PhD student at the IOP and the first author of the Mirror study. And it was her expert hand that photoshopped the absent staff into the group photos so seamlessly, as you can tell. You know, there's a few little ones that you can probably check. They're a bit out of place. So the protocol of the treat service and initial outcomes were first published in 2014 under this paper. And we found that the treat service and community titration was a successful alternative to traditional inpatient titration. So you can have a read of that if you've not seen that so far. It's been quite a while now. So things may have changed quite dramatically, but it gives the initial protocol of how treats were set up. Patient feedback reported that patients preferred the option to be cared for in the community, supported by their family and friends and around familiar surroundings, than being treated as an inpatient. And overall, this showed the possibility of an alternative strategy to increase availability of clozapine to patients with treatment-resistant schizophrenia. So how does treat function within SLAM? So SLAM is made up of several community mental health teams, along with outpatient services that cover the care of psychosis patients. And when one of these teams comes across a patient who they find is resistant to conventional treatments or is complex regarding their indications for certain antipsychotics, they are referred to the treat team. Once we have picked up the referral and accepted it, we invite these patients for a comprehensive review, which takes around 2 to 3 hours, including a full history, physical health examination, and investigations, including ECGs and a blood panel. The investigations, bloods in particular, are used to rule out any kind of biological causes of psychosis that could potentially be remedied outside the use of clozapine in particular. And the other investigations are primarily the kind of pre-clozapine investigations that one needs. Following that comprehensive assessment, every case is discussed at our multidisciplinary team meeting to formulate recommendations. Those recommendations are then passed on to the community mental health team, and we invite them to co-work with us if they would like to implement those recommendations. So what that typically means is, because TREAT's team is primarily made up of clinicians, doctors, and one clinical nurse specialist, one doctor is assigned one case, and the doctor will take, or the nurse will take, full control of prescribing and medical management of that patient whilst they're under a community clozapine titration. For the other psychosocial needs of the patient, such as psychology or occupational therapy or vocational services, the community mental health team will still take the lead on. We primarily focus on the medical aspect of treatment, including management of adverse effects as well. Once an optimum dose has been achieved, whether it's within the therapeutic range, a target dose, or a dose that is effective in treating the symptoms that the patient is happy and agreeable on, we then arrange a discharge meeting with the community mental health team to transfer care entirely back into their hands, so they will take over prescribing going forward. So TREAT is only ever a transient specialized service that aids in the initiation of clozapine, or in some cases we do augmentation and things like that, but for the interest of this talk, we'll focus just on titration. At any one time, we'll probably have about 100 patients on our caseload as well. But this, again, our usual turnover is about 3 months for each patient to get them optimized. Some go over as well. So once a patient is recommended for clozapine titration in the community, TREAT facilitates the prescription and monitoring of the patient, and they attend one of our outpatient clinics that cover about 4 boroughs in South London. We practice a reduced monitoring schedule, which can be seen here. And although weekly clozapine bloods continue for the first 18 weeks as per our company, so ZTAS is our monitoring company, regulations are. Physical health monitoring occurs here, including blood pressure, pulse rates, and physical examination. And within the first couple of weeks, they occur 5 times a week, and these start to reduce over time. Interestingly, due to COVID, we've had to amend this, particularly when the evidence came out that severe mental illness was one of the highest risk factors for mortality in COVID as well. So we reduced exposure to our patients during titration to 3 visits a week, with reduced monitoring as well, alongside those reduced visitation. So that's a protocol that we've had for a couple of years now. We've just collected some data on it, and we're looking to submit something to a journal soon, so you can keep an eye out for that. So that's an interesting new protocol that we have coming out as well. So our service is perhaps novel in moving the burden of clozapine titration from inpatient services to the community, and in doing so, aiming to improve access to clozapine care. And although the earlier work has showed it is possible to complete a titration, there remains some outstanding questions. And namely, what are the long outcomes and effectiveness of the treat service compared to inpatient services, including successive titrations, clinical outcomes, and longitudinal outcomes. Now, to address this in part, our group reviewed the patients of the treat service using a naturalistic mirror design study of patients recommended for clozapine by treat, using data extracted from electronic healthcare records. And this is the publication that just came out in the British Journal of Psychiatry. The inclusion criteria for this study included that patients had to be assessed by treat from 1st of December 2011 to 31st of December 2017. Treat recommended, one of the other conclusions, sorry, was that treat had to recommend clozapine as the primary treatment option, and patients who were recommended clozapine and consented for initiation were then titrated by either treat or HTT in the community, or referred to an inpatient titration should community titration not be feasible. So instances like this include, for example, the patient lives too far from the clinic, or HTT, it's too far of a distance to travel for them regularly to attend these community titrations. But it must be said that riskier patients, whether to do with their mental state or physical health comorbidities, may have been referred to inpatient services for titration as well, as they would usually be deemed unsuitable for a community titration. And finally, service use data must be available for the 1- and 2-year periods directly prior to and following clozapine initiation, defined as at least 6 months of healthcare records for each of the 4 years of interest. And we'll go over the 4 years of interest in Mirror just in a moment. The primary exclusion criteria were patients who had received clozapine at any point in the 2 years prior to our initial treat assessment. And for the Mirror analyses, patients who had stopped clozapine within the first year of initiation. And for the purpose of this study, that was categorized as a failed titration. So this figure kind of summarizes the design of the Mirror study, which was specifically focused around the economic outcomes of clozapine titration. And the design compares data for each patient for a specific time period after clozapine initiation to data over the same length of time immediately prior to the intervention. And so patients essentially act as their own control as part of this study. And in this study in particular, the Mirror analyses were conducted at 1- and 2-year mirror periods. So as you can see, as a mirror, there'll be 4 time points to extract data from. And speaking of data to be extracted, they can be categorized under these three headings, the other ones on the next slide: feasibility data, service use data, and clinical outcomes. So under feasibility, data extracted included whether clozapine was recommended, in what setting clozapine was initiated, and whether the titration was successful. With a successful clozapine titration defined as either reaching a target dose or reaching the minimum threshold for therapeutic plasma levels of clozapine, which 0.35 milligrams per litre was used for. For service use data collected, what we extracted was what number of psych hospital admissions and outpatient visits, which encompass visits to psychiatrists and allied healthcare professionals. These were, all this data was extracted to determine if there were financial cost differences in patients accessing these mental health services pre and post clozapine initiation. And finally, the clinical outcomes. So the clinical outcomes that were extracted were namely through the use of these clinical scales. So positive and negative syndrome scale is performed by a clinician for every patient referred to treat at assessment and at discharge. From PANS, we were able to determine the impact of clozapine management on psychotic symptom severity. But we also extracted ONOS. Now, I'm not sure if you guys have an equivalent to ONOS in Canada or if you use it yourself, but it stands for the Health of the Nation Outcomes Scale. It was developed by the Royal College of Psychiatrists in 1996 after being commissioned by the Department of Health in the UK. So it provides a broader measure of overall mental health symptom severity, using additional mental and physical health problems and functional status as well. These are relatively routine, well, hopefully routinely collected in English mental health services. And some of the components can be seen here on the right. So on the top, you tend to have more of the physical and mental health kind of parameters. And as we reach number 9, we see more of the functional outcomes that are recorded. So moving on to the results. Now, it's a busy slide, I know, and I'll try and summarize it, but it gives a nice little flow of how we recruited patients for the study. So it was a retrospective electronic healthcare record data extraction, but we had to extract according to our inclusion criteria. So we had 158 patients who were recommended clozapine by treat, and of these, 98 had accepted and consented to the clozapine titration. The 60 that declined voiced various reasons, including dislike of monitoring requirements or difficult social situations at the time as well. So they may well have returned to us at a later stage, but that's not captured here. Of the 98 that accepted clozapine, 52 were titrated by treat, 19 by home treatment team, and 17 were titrated as an inpatient. After excluding those failed titrations and missing data sets, a total of 30 treat, 11 home treatment team, and 10 inpatient data sets were included in the 1-year mirror, while 22 treat, 9 home treatment team, and 9 inpatient data sets were included in the 2-year mirror. Now, in terms of the success rates of titration, there was no indication of a difference between titration in the community and as an inpatient, with inpatient titration success rates approximately being 59%, while treat titration specifically from the community, so as you can see, the community as a whole, it says 67.6, but treat titration specifically from the community group had a success rate of 65%. Now, it's important to say that this study was not powered to test for non-inferiority, so a further study is needed to establish this, but just off face value, it provides a promising kind of bit of pilot data saying that this is certainly a feasible long-term method of titration. Now, as expected, the median length of the titration was slightly longer in the community compared to as an inpatient, as the community protocol's increase of clozapine is at a much slower rate to ease management of adverse effects and to accommodate for a reduced monitoring schedule as well. So when examining PANS scores for patients, that's included here, starting on clozapine overall. So this is the overall group, including community and inpatient titrations together. There was a significant reduction in all symptom domains. But even when considering community-only titrations, there was a similar significant global reduction of PANS, with PANS at baseline in the community averaging at 78, and while at discharge, an average of 50. So I've not shown that data here, but it's in the supplemental information of the paper. And similarly, from our ONOS scores, we found a significant reduction over the 2 years follow-up, including our post-hoc analysis as well. Now, the next few slides are graph heavy. So I'll give you a moment to have a look at them, but I'll summarize them while you do. So these graphs show the significant reduction of the cost of contact with services at 1 and 2 years post-clozapine initiation. And again, this is for the whole group. Home treatment team and inpatient services together. And in this slide, the graphs indicate significant reductions in outpatient visits in particular at the same time points as well. So significant reductions across the board. And finally, this graph shows, these graphs show patient level data showing the significant reduction in inpatient visits following initiation of clozapine. So at 1 year, you're seeing a few individuals who may need to go in for admission in the 1 year follow-up. These could be, I think primarily from this data set, they were from retitration due to non-adherence. And at the 2 year stage, we see that again, seems to be a very significant reduction to inpatient psychiatric visits as well. Now, again, those graphs are from the overall data set where the data found a reduction of cost of contact as a whole. Now, in terms of what we found in the community only sample as well. So as you can see here in the overall sample at 1 year, they found the cost of contact reduction to be £963, whilst at 2 years, it was £1,598 per patient. But even looking at our community and treat only sample, we found the similar significant reductions in contacting services. So at 1 year, the median reduction of outpatient visits was 50%, with a reduction of 45% at 2 years. And the total cost reduction from contacting services was £827 at 1 year and £1,686 at 2 years. But in terms of evaluating the clinical service, I guess a rather important finding was the rates of clozapine titration success, and that they were similar between inpatient and community titration settings. And the significant reduction found in PANS was similar again in terms of their outcomes, their clinical outcomes, and HONOS as well, which gives us a better image of their functionality. So we're seeing that it's hopefully on a similar level, although further studies are certainly needed to test for non-inferiority testing. But it's important to note that this study did not have the granular level data to determine the exact costs of titration, as opposed to the cost saved secondary to contact reduction. So the primary focus of this study is just determining how frequently patients are attending prior to clozapine and post, and determining a cost analysis of that. But a next step would be brilliant, would be determining the actual cost of titrations themselves to determine the amount of money that could be potentially saved from using a community titration model. It's estimated in this paper that the inpatient titration cost would cost around £12,000, whilst the titration with treat would be substantially less at 1,180. So this is an aspect that we're looking to explore at the moment with reviewing in greater detail reasons for refusal, so that 60 patients that denied or did not consent to clozapine initiation, and management of adverse effects in the community as well. So it's a bit of a summary of our findings and a bit of a whistle-stop tour, so thank you. I just want to recap some of our learning objectives. So we've had the opportunity to discuss the treat service and had a quick overview of how it functions within the wider healthcare system in SLAM. We've also gone through the methods employed in the MIRROR study, including the extent of the cost analysis, and possibly also identifying the need for a more rigorous analysis to understand variations in clozapine titration itself and the economic benefits potentially of a community model. And finally, we've talked through the results of the study exploring the clinical and economic benefits of a community model of clozapine titration. So thank you for listening to my talk today, everyone. It's been a pleasure coming here to speak to you. But hopefully, you found it interesting. albeit it was a summary of quite a large body of work that we've been going through at the moment. I've listed some take-home messages here, but I guess my own summary is that we've run the treat service now for about 10 years, titrated many patients in the community who are now established and under low intensity treatment teams. We've published a couple of papers evidencing the feasibility of the model and have more work in the pipeline to be submitted in the near future. But what would be a great next step for us is gathering more data from a wider population. So should you be interested in setting up a similar service or considering collecting data from services that are already functioning, we would be happy to meet and share details about our work. And I went through a summary of how the treat service functions in terms of its protocol. But the protocol that I wrote is obviously a lot more in depth. And if you'd like to know more about that or have a copy of that, or ask any questions on that, please feel free to contact me. And I can go through the details and we can arrange a conversation around that, and perhaps even our novel COVID protocol as well. In terms of thank yous, I want to say a big thank you to Emma Butler, who was the first author of this study, and which is the first chapter of her PhD, which is looking at epidemiology and clozapine. And of course, a big thank you to all the treat staff, past and present, and includes Oliver Howes as well. So yeah, I've added our contact information here, so please do get in touch if you'd like to discuss anything further. I'd be happy to take any of your questions now, but if you think of a question afterwards, then don't worry, you can feel free to send me an email and I'll get back to you as soon as possible. Thank you very much.
Well, thank you, Ati. And there's a lot of interesting parallels between what you're doing and what we're also doing here in Vancouver. But let me see who in our audience has a question right off the bat. Looks like Dr. Neelakant has something.
Thank you, Randall, and thank you, Ati. It was an excellent presentation. A lot of questions. I don't want to take over the Q&A here, but maybe the first one is, like, I know you said like the three things there, right? So you have the treat, you have the community, you have the home. So I understood the difference between home and the treat. Treat is outpatient based, and community, you said, home based is reaching out to the patient in their house. Apart from that, is there any difference? And how is community different from those two?
Sorry, so when I used the umbrella of community, it was to include both the treat service and the home treatment team. So the treat service is an outpatient service, so it's based at either the Maudsley Hospital or our Croydon hospital kind of premises, and patients visit the clinic to kind of undergo a titration there. The home treatment team, you can think of it as the inverse of us. So they move their staff to the patients to get to start off their titration and do monitoring at home. So I use the umbrella of community to say these are the two things that you can access for a community-based titration, with inpatient titration being something that obviously that is led by the hospitals instead.
Thank you, that helps. The other thing that I found very interesting was you were looking for 40% response on BPRS, which is like way more higher than what Keynes et al. Did, but they did only with the PANS, only 4 questions. Is this for the whole of the BPRS, or did they kind of look at those specific 4 questions that Keynes et al. Looked at?
So that's the Yoshimura study, wasn't it? So the 2017 paper. Yeah. So I think that was I could only get access to an abstract for that, actually. So I think it was just a poster presentation. The paper itself was based off a previous study that they had run, a large clinical trial, and they were just using a retrospective analysis of the data that they already had, just to discover something extra. So I believe it just said BPRS as a whole, a greater than 40% BPRS in the abstract. So it probably is just a generalized as opposed to the focus questions that were included in Kane.
Thank you. I'll let others ask questions. If there's a gap, I have a few more questions later on. I think there's a question from
Yeah, we we do have a question submitted in the chat. Ati, can you see that?
Yeah, so and that's why I flung back to the flow chart here. So it says there were 10 clients who were retried on clozapine, and which of these streams did they fall under and how many? Apologies if I missed this. So these weren't included in any of the analyses because it would have given us, it would have given difficulty in interpreting the data because they would have essentially had 2 titrations over that time. So we excluded anyone who had what we defined as a failed titration, which is they had to stop within the first year and kind of be restarted at a later date. We only had people who had just 1 titration during this whole time.
And while we're on this chart, I have a question. The inpatient titrations, how were those selected? We here have developed some criteria for community versus inpatient titrations. So do you have such criteria?
For inpatient titrations, honestly, it's more risk-led as opposed to anything else. We haven't got a strict set of criteria. And I guess the reason behind that is following the birth of Treat, I think initially we were perhaps a bit more intent on being as safe as possible and taking the least risky patients and taking them forward for a complete clozapine titration. But over time and experience, I think we learned to manage cases that would even be seen by the home treatment team. I mean, I guess that comes from the expertise of the consultants and the registrars and so on and so forth. So the patients that typically go for inpatient titrations are those that are deemed unable to go to treat. And the vast majority of patients that do now need a clozapine titration, they either go through treat or they are initiated initiated in hospital after a mental health act assessment. So they've been sectioned and have been admitted into hospital, and during that process, clozapine was deemed to be the effective choice. So we haven't got a criteria per se, but it'd be interesting to see what your criteria are actually, because see if we can develop a similar set of protocols over here in London.
Well, we could share those with you. They're, you know, they were based upon just a consensus conversation between psychiatrists in the community and those in acute settings. And, you know, that really it has to do with comorbid conditions for the most part, whether it be substance use or medical conditions, etc.
We are quite privileged in SLAM in that our colleagues are pretty much based just across the road. So King's College Hospital is based just across the road from the Maudsley Hospital, and that's where the primary site of treat is. So we have quite a lot of physical health colleagues and cardiology colleagues in particular who are of great help. And quite a few of our clinicians were not psych in their background. So myself included, I mean, I wasn't psychiatry in background. I landed in psychiatry following a pursuit of a career in acute medicine and gastroenterology as well. So we became, I guess, because we're early on in our career, we're a bit more, and we still do quite a bit of physical health work in those hospitals as well. We were able to, I guess, feel a bit more confident with managing of those physical health symptoms or comorbidities that are associated with clozapine as well.
Thank you. Dr. Elikant said he has more questions, but before we let him present those to you, I just wonder if anyone else has any questions. We do have 2 members from our early psychosis intervention team based in the community. I wonder if they have any questions. I'm just thinking along the lines of, are there special considerations for that kind of population?
I guess while we're waiting to see if they have any questions at all, I get the answer to that is yes, we do have. So if we have a referral from one of our 4 early intervention services that exist across the trust, we do tend to prioritize them, given the evidence of early treatment leads to better outcomes, essentially. There is now currently a couple of QI projects ongoing to optimize clozapine treatment in early intervention services. So these are led by Dr. Serena Lai and Dr. Rob Harland, who's one of the associate clinical directors of SLAM as well. So I was in the process of developing a pathway for the trust as a whole, in terms from referral to mental health services, through psychosis to to establishing treatment resistance as quick as feasibly possible, if indicated. So it is some ongoing work, a big project that we're working on at the moment as well. So yeah, there is certainly due consideration for early intervention, for sure.
Yeah, I don't have any specific question at this point, but I'll be interested to learn more about how the early interventions over at London may connect with you in the future. Yeah.
Yeah, absolutely. I mean, so we have we have 4 EIA early intervention services and 1 clinical high risk service as well, known as Oasis. That's led by Professor Paolo Fusipoli. The early intervention services kind of came under Professor Philip Maguire, and the consultants there are across Lambeth, Southwark, so the 4 boroughs. They have a very high referral rate. South London is it's a very urbanized area, very high rates of psychosis. We have lots of first and second generation immigrants from Africa, the Caribbean, India, Sri Lanka, a lot of post-colonial and wartime asylum seekers and refugees as well. So very high rates of psychosis amongst quite a diverse population. So it's a bit of a priority under the Institute of Psychiatry and SLAM as a whole at the moment, to address the needs of this at-risk population. I've worked a lot with the early intervention services. I wish I could go into the details of how it's set up, but I'd be more than happy to redirect you to a few of my colleagues. I'm not sure if you're aware of an academic called Dr. Samir Johar. He's the lead consultant in our Croydon early intervention service, and he's done a lot of work around early intervention services and mood disorders as well, actually.
Thank you. I'm gonna connect with them.
For sure. And then I guess I have one question, if I could potentially flip it around the other way. So before I came in, Angie and Philip gave me quite a nice introduction to how community clozapine, I guess, is established around your network and your services, and how what I kind of gleaned from that is decentralizing clozapine titration away from a kind of specialized service into the hands of everyone. So everyone should feel more familiar with clozapine and have the necessary tools and knowledge to initiate it themselves. I guess, what are your thoughts on us as Treat in the other direction, as a unique service that is designed to capture all the clozapine titration traffic and kind of pigeonhole them into the appropriate avenues of titration? So whether it be with us or home treatment team or hospital-led titration as well, because I can, they're 2 other opposite sides of the pole, I imagine, to accomplish the same goal.
I can go for that. I can take that question. So what you described, the Treat, is what we have seen south of Vancouver in Fraser Valley. They have a PTOP psychosis treatment optimization program, which is very similar to what you have described. They have a team that kind of looks at the negative syndrome, the clozapine, and all aspects, longitudinal review of records and stuff like that. Very big program, but it's changed quite significantly, and it's kind of dissipated in the community now, more decentralized. And we used to have AHPT accused home-based treatment or crisis intervention program, which was like equivalent of like home-based treatment that you described, going to people's homes to start. And it's been overwhelmed and it's not available for us, and it's been difficult. three, I think we find that a lot of patients just drop off the clozapine in the community, and the skills have kind of have been disappearing. So what we have been trying to do is take this new stance and working with this.
Brilliant.
Anyone else can add, so I thought I'll just quickly. I have a question for you. I was like very impressed with the numbers that you had for the treat. 58%. For people to come from all over London, it's crazy to travel from what I have seen. So for people to come there 3 times a week, 5 times a week must be like very difficult. Do you give out like train tickets or bus tickets to these patients? And what do you do that you have such good response? Of course, you have a great team, so maybe that attracts people and maybe make them stay.
Yeah, so there are various things to consider. So we don't have just one clinic site. So we have one site that covers 3 boroughs. That's based at the Maudsley, which is almost like a travel hub. So all buses that come across South London basically travel through that Maudsley Hospital area. And we also have quite a nice train station there as well that connects to the hospital. So it's a 2-minute walk from the train station to the hospital. And a lot of our patients in the community are given freedom passes. So for use of public transport, which is, it's the lifeblood of London, frankly. You can't move in a car here at all. You either have to ride a bike, walk, or take public transport. And for our Croydon colleagues, it's difficult for me to consider because Croydon's a lot more sparsed out. It's a lot wider. I have no idea how they manage to get their patients to keep coming to the Croydon site, because it is a journey, but they continue to come. And I think a lot of it is due to perhaps support from the family and the team as well. I think what we've found over time is that the community mental health teams have developed a favorable opinion of this, to the degree where if they find anyone who's considered of treatment resistance, they refer to us straight away, and they really encourage and support their clients to attend. So we know care coordinators will sometimes escort their clients for the first few appointments with treat until they establish a rhythm and so forth. It's hard for me to consider going back to the pre-COVID protocol, which was they would come in the morning. During the first week, they'd come in the morning, they'd have their tablets in front of us, then they'd have to wait 3 hours in the waiting room whilst we do physical health monitoring hourly, then go home and then come back the next day. So they would do that 5 times a week, 5 times a day for the first 2 weeks at least. Now it's a very different protocol. So now we see them in the morning, we give them their tablet to take at home at nighttime, so we evening load their dose. And when we review them in the morning, it's just a physical health assessment, is everything okay, mental state exam, and then send them home with another two days of medication. So primarily evening loading the dose so as to prevent or decrease the risk of any kind of posture or hypertension related accidents.
Awesome, thank you. That's very informative. We did have a bit of a struggle with that nighttime first loading dose as well. A lot of debating, but I think that's ultimately what works out better. And also, just curious, I see your protocols end in like 5 weeks, right?
Yeah.
Just curious about your myocarditis and granulocytosis rates, 1. 2, also, are you guys using the point of care device?
Yeah, so those are good questions, actually. So in terms of our myocarditis and agranulocytosis rate, so I've been with treat now for 4 years. I think I've must titrated dozens of patients, so probably in the hundreds. And I've seen 1 case of agranulocytosis, so probably the typical prevalence, incidence rate of 0.1, 0.01 to 0.1, as Stahl has reported a few times. Myocarditis a bit more frequent, although Professor McCabe's paper, or suspected myocarditis, I should say, because Professor McCabe's paper, so Professor James McCabe, who's professor of epidemiology, focusing around clozapine in particular. His work showed that, I think, he reviewed all these patients that were discontinued clozapine and deemed non-rechallengeable according to this suspected diagnosis of myocarditis. Got all the data, sat with a group of cardiologists who reviewed all the available investigations, and they ruled something like 10% of the patients who had suspected myocarditis actually had a myocarditis illness. So 90% or so, were suitable for a re-challenge. So that's an interesting thing. So I'm always a bit wary now about when putting forward rates of myocarditis. But yeah, I would say in line with the general public, I would say that perhaps there's evidence to say that rates of titration, the speed of your titration, is associated with the onset of agranulocytosis and myocarditis as well. Our rates are particularly slow. So in our old protocol, it was 12.5 milligrams that you'd start with, so half a tablet of Zapanex, which is our class of clozapine that we have here. And then in our current COVID protocol, we actually start smaller than that, so 6.25 milligrams, so a quarter of a 25 milligram tablet. So perhaps the slower rate has an impact on the lower numbers of those extreme kind of adverse events that we see within TREAT. In regards to your second question, the point of care testing, yes, we do. So we have a point of care testing for our full blood counts, which generates a FBC, which includes just white cell count, eosinophils, and neutrophils over 5 minutes. But interestingly enough, we also have a point of care testing for clozapine levels as well. So that's a capillary sample that we analyze, and that gives us, again, our clozapine levels within about 10 minutes, I'd say. So it prevents the typical delay of about 4 to 5 days for adjusting medication. And that's a very interesting project that's ongoing at the moment to help guide more precisely an appropriate clozapine dose for our target patients. The next project that SLAM's actually working on at the moment is capillary full blood counts as well for ZTAS monitoring. So we're waiting for approval to begin using capillary samples for full blood count approval, which when we did a few rounds of focus group testing with our clozapine patients, they said one of the biggest barriers to them starting clozapine in the first place on their end was having these blood tests so frequently. And so having a pinprick like you do for, they're very familiar, many of our patients have type 2 diabetes, they need their blood sugars tested. So they're very familiar with a pinprick analysis. So they said they'd be much more comfortable with monitoring in that form. So yeah, it's just some more work that is going on with the IOP and SLAM at the moment.
All right, Ati, thank you so much. We're pretty much out of time this morning. Maybe you could project your email address again, and anyone who wants to follow up with you can do so by email. We really appreciate your participation and your sharing your knowledge and experience.
Thank you very much for having me.
Yes, thank you, Ati. And I just wanted to note to everyone, thank you for coming this morning, and that we will share the recording along with a PDF of your slides, Ati, if that's okay. I can follow up with you on that, and your contact information will be in that last slide there. So if anyone wants to reach out, you kindly offered that. So thanks so much again. And also just to note that there's a really brief survey that pops up when you leave the webinar. We'd really appreciate if you could take a couple of minutes to fill that out. And thanks so much again, Ati, for a great presentation and discussion, and for everyone joining this morning.